Hello, everyone. Welcome to the UK NEQAS BTLP online event. I'm Richard Haggis, Director of UK NEQAS BTLP, and I'm proud to introduce today's webinar session, Learning from Experience.
Good afternoon, everybody. My name is Rob, as Richard said, and I work in the RCI lab at Barnsley NHS BT. So I've been asked to give you a brief run through of antibody identification techniques. So here we go. So what are we looking for and why we're looking for them? So these are red cell alloantibodies that we're trying to detect, trying to confirm, and we're obviously trying to detect them to avoid any sort of transfusion reaction, or for the case of hemolytic disease, obviously to avoid and monitor any hemolytic disease in the newborn. So that's what we're doing. That's what we're trying to do. So when we say we're looking for antibodies, we often use the term clinically significant or insignificant. So here we are. This is an antibody risk assessment for transfusion, and there's some quite obvious significant alloantibodies there: the ABO group, the RH, KEL, KID, Duffy, M and S. Actually, all the RH, all the big K, are they all significant? And then obviously we've got the insignificant ones: Lewis, the P, the N, the anti-LUA. And then obviously at the bottom, in the middle, we've got a collection of the weird and the wonderful, things like VEL, U, Cartwright, Duffy 3, things like that. These are things that come up in your antibody panel, pan-reactive, and are antibodies to high frequency antigens, or HTLA antigens. So one that most people have the antibodies for, antigen for, sorry. Some of these are significant, some are insignificant, and some fall in between. So for example, YTA, for example, is clinically significant if a strong example. Now, nobody tells us what a strong example is, but the advice is if it's a strong example, give YTA negative units. If it's weakly active, then you're fine just to issue that blood as suitable. So there's some that fall in between two stools. As regards to HDFN, some of those antibodies will switch sides for HDFN. So things like KPA, possibly not particularly significant for transfusion, but it's quite significant for HDFN. Same with anti-C Willis, CW. For transfusion, not really interested. We would give CW neg cross-match compatible, but actually we would monitor that antibody for HDFN. So they're not all as cut and dried as significant, depending on the situation. So you've done your antibody test. So, but how do we find them? How do we look for these antibodies? So the next slide will appear to be, we are RCI and we're showing off, but actually we're not. The basic difference between ourselves and potentially the guys in the blood bank is kit. It's the amount of panels and the amount of reagents that we've got. We specialize in antibody identification, the weird and the wonderful, whereas you guys have got, blood sciences departments, you've got lots of things going on. So your techniques and your technology are fairly limited compared to ours, but there's no difference in the staff, there's no difference in the training or the registration of the staff to detect these antibodies. So it's not a we're amazing sort of slide. But what it does sort of highlight is that obviously in the blood banks, you guys possibly have 3-cell screen, you may have an I18 and an enzyme panel, and you will have some form of DAT. In RCI, we've got a 2 and a 3-cell screen. We've got 2 standard panels that are different antigen profiles. So these are in IAT and enzyme. So we can use these by card, by list tube. We can try list tube. We've got 2 reference panels. So these are R1, R1 or R2, R2. So that all the cells, if you've got an anti-little c and you're struggling to exclude, or you've got an anti-little e and you're struggling to exclude, these panels are negative for those antigens. So you've got rid of that reactivity straight away. So you can find other additional alloantibodies there. We've also got different technology. So we've got BioView and BioRad on site, and obviously we've got the list tube. We have a rare cell panel, so we can detect the antigen neg cells if we suspect a high frequency antibody. We've got a multi-specific DAT, which not strictly speaking is to do with antibody identification, But if you've got a more specific DAT, you may be able to pick up IgM C3c, which may give you a clue, especially if you're looking at autoantibodies, where to aim your techniques or where to aim your tests, what to look for. And then we've got the full thread cell phenotyping, genotyping, and other things like that. So you've got an antibody, or you think you've got an antibody, your screen's caught positive, you've done an antibody ID panel, but you can't quite resolve, or you can't quite see what you're looking at. There looks like there might be a mixture, or you've not got enough negatives to exclude. So what can you do, or what do we do, shall we say? So you could try different techniques. You could even try different temperatures. Now I'm aware that's easy for me to say working in RCI, but you guys in the blood bank, you may not have the option of changing the temperature. You may not have a validated technique. You may not have a validated process for doing any of this, but it's just to show you what we would do, or what are the things to sort of look for. So if you look at this as a sort of standard antibody panel, you've got some reactivity there that's been noted, and you've got three different techniques. So in red is the IAT. This could be list tube, or it could be your column IAT result. So you've got some quite strong reactions, a few weak ones. In that panel, you've got probably what looks like multiple antibodies. So looking for different strengths, looking for different reactivity. So one, your IAT. I know you all like to look, but we've only got 15 minutes, so I'll just sort of skip through. So by IAT, you're detecting what you suspect is a big E plus big S plus KPA. So you try your enzyme panel, which is a blue one. So that's a second column. And you're just getting E plus KPA. So this has helped in two ways. It's removed the anti-big S, which allows you to do some more exclusions, or to identify that there's no additional antibodies there. It's also increased the strength of the anti-big E, so you can be more confident now that there's an anti-big E specificity there. Because whilst in your IAT you've got cells 3 and 5 positive, you've only got one big E pos, big S neg cell to confirm. So actually you need two big E pos, big S neg cells. So your enzyme panel will help you do that. And the KPA looks like it's still active there. And then the third one in green is a room temperature panel, saline room temperature. So this is done between 18 and 20 degrees and sort of an immediate spin, or a spin once you've incubated. And this is showing an anti-M. Now I've just put this on just to show that we see dosage quite a lot. So this is where you're getting a much stronger reaction with the homozygote M-pos cell, and then weak scruffy reaction with the heterozygote. So it's again something just to look out for when you're doing an antibody ID panel. You may get a reactivity that you think, well, that doesn't fit anything. It looks scruffy. But look for the homozygotes. If you've got quite clear, strong poses, it may be that the antibody is just showing a bit of dosage. So look for the homozygotes, and you might be able to have an inkling about what antibodies sort of present there. So that's fine. You've got those antibodies. You can sort of use different techniques, different temperatures. But what if you've got a pan-reactive antibody like this? So you could try a different technology. Again, I appreciate that not everybody in the blood bank can do this. But certain antibodies work better, inverted commas, in tube. The tube technique that we use, or that is used, is generally includes a wash phase, but obviously your cards don't. So whatever, if there's any interference or there's any reactivity in the patient's plasma, that will be trapped in the column and in the gel card. There's no way that you can get rid of that, and you will get non-specific reactivity. But with the list tube IAT, or the tube IAT, for example, all that reactivity will be removed. It will generally be washed off. So it's really good for if you've got samples at a hyper viscosity, you've got a lot of fibrin, cell debris, high white cell count that interfere with the column technique, but actually they're not genuine reactions, they're just nondescript interference, and it's part of what's in the patient's plasma. So we would do a list tube IAT, and that would clear. This is also true of patients with DARA, but we would do, you would use DTT reagent cells. So this is a very similar reactivity to DARA. The panel, the IAT and the enzyme are pan-reactive, the auto is negative. And it's just a good way to remove that. So that's alloantibodies. Now, obviously in RCI, we see quite a lot, well, a heck of a lot of pan-reactive autoantibodies due to autoimmune hemolytic anemia and MDS cases, things like that. So how do we resolve those? So this is a typical, what we call a warm autoimmune hemolytic anemia. It's a pan-reactive, quite strong pan-reactive IAT and enzyme. It's got a strong 5+ auto and quite a strong IgG DAT pulse, as you can see in the bottom corner. So we can't exclude anything, we can't identify anything in this case. So we need to do something about that. So what we do in RCI is we perform what's called an absorption. So this is where we incubate the patient's plasma with 2 different aliquots of red cells. You can see on the bottom, they should be antigenically mismatched, if you like, and I'll explain that on the next slide. But the idea behind this is that the absorption cells remove autoantibody, but leave behind any alloantibodies present. So for this example, let's think about an auto-anti-D or an anti-D antibody there in the plasma. So this patient's got an anti-D that's hiding underneath the autoantibody, if you like. So we use the absorption cells to remove all the autoantibody, but leave behind the alloantibodies that we want to look at. So this is basically how the absorption process works. So we incubate the patient's plasma on both sets of absorption cells. You can either do it at 37 or 4 degrees, depending on the specificity of the auto. It may be a warm autoantibody, it may be a cold autoantibody, it could be a mixture of both, so we can modify the temperature. So 1 aliquot of the patient's red cells, the patient's plasma go onto the D positive red cells, and 1 aliquot of the patient's plasma goes onto the D negative red cells. We incubate those for 15 minutes, remove the plasma, put that on a new set of absorption cells. And by the end of the process, you will have 2 aliquots of patient plasma to test, and you just perform antibody identification on this. So the set of patient plasma that's been incubated with the D pos cells will have removed all the autoantibody and the anti-D antibody. The D negative absorption cells will just remove the autoantibody, just leaving behind the anti-D. It could work for any other antibody, KID or whatever, but I've just used anti-D in this example. So you can see now it might make a little bit more sense. So if you look at the R1R1 panel, that's got nothing in it. So the anti-D is bound to the D positive absorption cells and been removed from the plasma along with the autoantibody. But on the little r cells that are D negative, there's nowhere for the anti-D to go. So it's still there in the plasma. But what it has done is remove the autoantibody, so we can identify there's an anti-D underlying on that patient. And the last slide I just want to mention is elution. So this is sort of the opposite. This is where you don't find an antibody, but you want to detect if there is one. This is done post-transfusion, usually if a positive DAT is formed in the patient since the last transfusion. So you would do an antibody screen, antibody panel, and get nothing in it, get negative result. Great, brilliant, we can cross-match you again. Actually, you can't. Well, you shouldn't. Because what you might be missing is bound antibody from the previous transfusion. So let's imagine in this case, this patient's formed an anti-JKA to the previous transfusion, but all the anti-JKA that this patient's produced is bound to the previously transfused red cells. You can't see it because it's not free in the patient's plasma. So we perform an elution, which basically is an acid elution. It dissociates the antibody from the red cells, and therefore it's free in the supernatant and free in the plasma again, and we can perform an antibody ID on it. So we can detect an undetectable antibody, if you like. So this would be anti-JK, if I've got the positive eggs in the right place. And that's it. Excuse me, that's my talk done. Thank you very much.
So my brief was phenotyping, and I was going to do something slightly different, but based on the feedback from the last webinar, I thought I'd take you through how a scheme, sorry, it's called a program, how a program goes from start to finish theoretically. So we're going to go through the very beginning of a program to a fully accredited scored scheme program. I've only just changed the name. Where we're at with extended red cell phenotyping at the moment, and some of the lessons learned. So we start off with an idea. Do we want a new program? And why might we want to do this? So there may have been changes to technology. It might be that some participants have asked us to set up a new program. It might be that we want to expand on or extend a current program. For example, extended red cell phenotyping has branched off from the pre-transfusion testing to allow RH and K to be on every R exercise, which is the one with all the cross-matching and everything, 4 times a year. And that's because we know that a lot of people do RH and K as standard. But the other phenotypes, for example, JKA, we saw lots of errors in JKA typing recently. But because we needed to go across all the blood groups, we would only send out samples for testing for that antibody group every 2 years. So it wasn't really doing the job that we wanted it to. Another thing is, do we have the sufficient scientific knowledge ourselves? So we have a program advisor, Shane Grimsley, which some of you may know, for our genotyping scheme. So when we've decided that we are going to probably be doing something, we may send out questionnaires asking, are you interested? What kind of information might you want out of it? And we have a think about whether or not we can share material from programs we've got at the moment. So the diagnostic Clyhouse scheme, which is very much a pre-pilot, what we will probably be doing at some point is we will send out a standard FMH exercise, and we will send out a survey monkey saying, if this was a patient of this variety, what would you do? And at this point, we don't really know what information we need, so we would use SurveyMonkey to gather data rather than have our IT guys spend weeks and weeks building something when we don't know what we really want yet. And samples may go out irregularly, and we might pop them in with some other samples that are going out at the same time until we've figured out what we want to do. And at this point, it's probably not steered. So we've got a steering committee which oversees everything we do, which is it's about a dozen people who work in labs and are specialists, and we've got a spread of different technology users, we've got clinicians. We try and make sure we've got representation from all the people we serve. We also have scientific advisory groups that will look at more specialised schemes. So FMH has one, genotyping has one, but a pre-pilot would just be ideas being thrown around pretty much. We were trying to figure out what data we wanted to gather and why. So do we want to gather the reaction grades for extended red cell phenotyping? We think that's useful. One of the things we're going to be doing at some point is we're going to be adding in an interpretation. So if you report to us that you got a weak or a 1+ reaction and the antigen is expected to be negative, then that's technically incorrect. But if you wouldn't report that, then we shouldn't be giving you any penalty points for that. And we need to consider the costs. So I don't know if you're aware, but we are run as a not-for-profit. We don't make any money. What we have that's extra goes towards investing in future programs. And does anyone want it? So a good example, if we make a loss, that doesn't necessarily mean we won't run it, but the A1 typing is currently involved in every ABO titration scheme we run. We thought about, do we need to branch that off so it's a completely separate thing? So we sent out a questionnaire and asked, do you want to do A1 typing? Are you already doing ABO titration? There was only one lab in the UK that was interested in A1 typing that wasn't already doing ABO titration. So we think, you know what, rather than branching that off, it can just all stay together. It'll save money for us, which saves money for you. And feedback, feedback, feedback. We can't do anything unless we know what it is you want us to do. If we made up a program that we thought was brilliant, but no one wanted it, then that's not good for anyone. So once we've decided to go ahead and we've got a little bit of information, first thing we need to do is we need to apply to UK NEQAS, the overarching group, for permission, because we've got a no overlap deal, which seems sensible. We advertise, so we will send out in our newsletters at re-registration. We will mention at webinars and annual meetings. We might put out flyers with some of our results saying, hey, new scheme coming. We have to figure out what to charge. So the pilots are cheaper than full schemes because we don't have the full-on IT built yet, and we're not performance monitoring, and we're not spending as much time making sure that everything is absolutely spot on to UCAS standards at this point. And then we need to build it into our annual unit plan. So this includes things like, when are we going to send the samples out? How are we going to do that? When are we going to bottle it? When are we going to use the lab? How is it going to be packed? Because everything is shared between us and haematology. And I think between us, we've got 50 different programs and combinations of everything. So shoehorning things in, it has to fit for everybody. And we would send out more regular samples. And we would have better IT. And we would then need to be training our staff to make sure we knew what we were doing in terms of pooling material, planning material, how the lab tests we were going to do are going to work. When we go to look at and review the lab test results, what are we looking at? And then we would start the document control. So we need an SOP, we need instructions that would go out with the samples, we need a blank data entry sheet for you to send results back. The registration form would need to be amended, the schedules need to be amended, we need all our lab worksheets and serology review paperwork. And 2-pager, there's this one, this is the biggest stage really. We then play with the exercise format. So anyone who's enrolled in antenatal titration will have seen that we've been varying the number of samples we send out, what's in the samples, do we send out cells as well, do we not? And we're at this moment trying to figure out exactly what we need to send out to get to the end point where we know whether or not your testing processes are safe. And we'll figure out what data we need to collect. So we will figure out as we go through, do you know what, I wish we'd asked that question. And that's when we'll start adding questionnaires in. And at this point, we'll be setting and monitoring KPIs. We don't need to have KPIs if it's not accredited, but we do. And we need to figure out what is actually manageable. So you'll see for our pilot schemes, the reporting deadlines are longer than for the full programs. And we create an annual plan. So over the course of the year, we want to make sure we cover a little C negative for extended red cell phenotyping, possibly 2 D negatives, a Duffy A negative and a Duffy B negative in one patient, so that we can look for some of the more unusual things, and JKA heterozygotes because we know there's an issue there. So we will figure out how many samples we're going to be sending out, how we're going to be scoring. So for extended red cell phenotyping, we have put together 4 models of how we think we might score it, all based on the pre-transfusion testing model of scoring. And what we want to get out of a scoring system is we want to make sure we're capturing the people who are sending results that are concerning. We want to make sure that we're not overwhelming ourselves and you by sending out letters to everybody who makes any mistakes whatsoever, because that's just not realistic. So the models we've put together, they also have to be try to be easy to understand, because otherwise we'll get very confused, let alone you guys. There has been a recommendation from the previous webinar that we explain how FMH scoring works. That is something that we will probably be doing at some point. And then in the background, we do shadow scoring, which we find it impossible to not go mwahaha while we say shadow scoring. And this is to check that the scoring models we're thinking about are going to be working. And then the scoring models get submitted to the steering committee or the scientific advisory group that we think we might be using, and also to the National Quality Assurance Advisory Panel. And for extended red cell phenotyping, that's happening this week for both of those. And we ask for feedback. If you have any ideas, you want more samples, less samples, different samples, let us know. And then we go to a fully scored program. We would advertise that this has happened. What we have seen is a lot of emails bounce back to us because people's email addresses aren't up to date, and then you don't find out that they're live. So if you think you're not getting the emails you should be getting, please get in contact and we'll make sure you've got the correct email address. We will then start performance monitoring, which is me and Richard sitting, poring over the results and trying to decide what is actually important, how we're going to address any issues. If we're going to write a letter, we'll look at the significance of the errors. So a false negative cross-match is worse than a false positive cross-match. We'll also look at if we've been in conversation with you during the exercise or after the exercise. What have you said to us? Have you started investigating already? And also what's happened in the last year or so. We will update the participants manual and feedback. You probably wouldn't believe how much we appreciate your feedback, but we really do. So once it's a scored program, we will then go to getting it accredited. So we need to do a huge audit. Thank you very much, Claire. And we will apply to UCAS for extension to scope, which is, I guess, exactly the same as you guys would do, but to a different ISO standard, and more feedback. And we would regularly assess the content of the samples, of the schemes, the aims, how we're scoring. And we're always looking to see, are people not being flagged up when we could help you? Or are we sending out too many letters and actually annoying you when you find? We want to find the balance between that. So where is extended red cell phenotyping at the moment? So it's still currently a pilot. We have an annual plan. We've got 4 scoring models. We have a favourite. And once that's been approved, we will get the IT changes put in, and that will allow us to put scores in the reports as well. That will be useful. And in the meantime, we continue to shadow score. And any feedback, bring it to us, please. And our plan is to go to a full scored scheme for 2022-23 in a year's time. So why am I talking about particularly for this? Well, we've seen a lot of errors over the last 2 years. 80 labs have made errors in extended red cell phenotyping, with a total of 147 errors. And that's from 1,034 sets of results over 8 exercises, which comes to 7.7% of labs making errors and 1.8 errors per lab returning results, not per lab making errors, per lab returning results. So our steering committee very wisely said, why don't you crack on with scoring this one? And they were not wrong. So I've done a look back, and over the last 2 years, of the 147 errors, you see that 70 of them were false negative JK and false negative other groups, and those are concerning, with 44 of 147 being false JK errors. The other ones are people switching samples, testing old exercises, testing just some of the tests the wrong way around. For example, if it was a Duffy Kid card, maybe those have got switched around, particularly if there's manual. And some of them we aren't sure what's happened. So in November 2020, we sent out a questionnaire following lots and lots of JKA typing errors. And we asked you to tell us what reagents you were using, what your technique was, did you believe you were following the insert, what controls do you use? We got 70 responses back, which is pretty good. The main key, what I took from that, is that it was variation. And when I went to look at the insert for our reagents, I was convinced I knew what the technique was. I was wrong. So is there a quick fix? There may be some rapid fixes. Check the package insert, which me saying that seems very condescending, but actually, I bet some of you are using it incorrectly. Check your centrifuge settings. This is a particular one with desktop centrifuges. So if you think that you could have the speed displayed in G or in RPM, and if someone's hit a button and just played around with that for something, and then you think it's set to 1000 G, but actually it's set to 1000 RPM, and if it's a small benchtop centrifuge, it's probably not going fast enough. Your cells might not pack, false negatives, and that's exactly what we're seeing in our results. Check you're using a heterozygous positive control, and check you're using it at an appropriate frequency. So particularly for JKA, if it's a tube test with an anti-sera and you're using a homozygous positive control and that spins and it comes out and it's fine, but you've got a negative result for your patient, could that be because you're using a homozygous positive control and your centrifuge isn't spinning enough? So that's the end of me. So please put your questions in. Give us your feedback, please, at btlp@uknequas.org.uk.
Oh, there we go. Right, okay, a little bit of history. So the IT guidelines actually started back in 2000 as the guidelines to blood bank computing. We then had another iteration in 2006 around, which was called the specification and use of information technology in blood transfusion practice. These are all very wordy. And then in 2014, they became the specification, implementation and management of IT systems in hospital transfusion laboratories. You'll be very pleased to know we haven't changed the name again. I was like, we don't want to change that name again. We've already had three iterations of the name. Let's keep it the name as it was the last time. You know, we had the opportunity to change it. It's quite long, but I think it sums it up. So the writing group was myself, Chloe George, who works for the Welsh Blood Service, Paul Ashford, who works in industry for transfusion IT, Tom Bullock, who will be well known to lots of people from RCI, Tony Coates, who's still up in Wrexham and is also a transfusion lab manager. Linda Lodge, who works at NHSBT in Scotland, which is the wrong terminology, apologies for that. Nishal Patel, who is a consultant at the Royal Free. Megan Rowley, who will be well known to lots of people, who's currently also in Scotland. Oh, that's interesting. And Nigel Sargent, who at the time when we started writing the guidelines worked in Basingstoke, but now works on the south coast. So as you see, a mixture of experiences and mixture of interests, and it was quite a nice group and we worked quite well together. It has taken us a little while due to COVID as much as anything. The problems we've had with this guideline is the guideline in 2014 was very long. It was already very long in 2014 and it was complicated. And by the time we put all the things in that we wanted to add in, it became slightly longer. And we were like, oh no, it's even longer. We wanted to try and shorten it if we could. And actually, it was too long to publish. No publication would actually publish it as the length it was at the beginning. So what we've actually done, and this is where the delay has happened, is we've actually spent some time pulling some of the sections out of the main guideline and putting them into appendices. These were sections such as all the pre-work that needs to go on around before you go out to tender for an IT system, all the stuff about domains, which are really important, but actually people don't look at them even on a monthly basis. They probably look at them probably when they're like getting fed up with their IT system and thinking about moving to a new IT system and people are talking to them about that sort of thing. So we've put those into appendices outside the main body of the document, and actually what that will do is that will actually mean that it's they won't be published in a printed copy, but they will be available on the website. So they'll always be available for people to see, and this is to actually help us help people use that guideline. We want it to be as user-friendly as possible. It's quite difficult in an IT guideline, but it was important to us. So what has changed? So we've put quite a bit of clarification in around the infrastructure requirements. So more detailed information about the expectation on the number of environments you need. I'm sure those of us who've got very old IT systems are used to probably only having 1 or 2 environments, hopefully 2. But actually you need more than that. And we've actually put a lot of information in there around what you need. And it's so that when you're going and talking to suppliers, you've got the information that they'll start telling you what they think you need. And you've got a little bit more information yourself about what is appropriate to a guideline. We've also included some additional information about data integrity. Because obviously patient records now have to be in line with the Data Protection Act and GDPR. So we've included that. That's really important. What's new? So you may not know this, but most of your IT systems out there are actually classed as an in vivo diagnostic device, an IVD. And that's because LIMS systems tend to use algorithms. If you've got a LIMS system that never uses an algorithm, you're probably not an IVD, but I suspect there aren't very many out there, if any. So by an algorithm, what I'm saying is things like the patient's an A, you got something that blocks them, you've got something that blocks you giving them a B red cell. That is an algorithm. It's an algorithm that makes sure that what you are doing is correct for your patient. And so by that way, that makes it an IVD. And there isn't a huge amount different around it being an IVD, just a little bit more, mainly for suppliers. So we've put in a section around clinical decision support. Now, planning for electronic prescriptions and clinical decision support must be robust. Now, I've been very lucky. We've been using electronic prescriptions for quite a long time in Oxford. It was something we were very passionate about getting into place, and we've actually used it a lot, and it's very helpful. But you must make sure that what you're doing is doing it in the right way. So we've got the advice around using the normal patient identifiers. Think about products. Don't just do it for group and saves. Don't just do it for red cells. Do it for all the products. So that must be specified, and they'll all be slightly different depending on what product you're thinking about. You can use it for encouraging single unit ordering, which we've done a lot of, and actually we've, our single unit ordering now is very, very good in Oxford. I suspect it's better than we've ever seen it in the past. It allows you to use national triggers to allow benchmarking. So if you wanted to benchmark yourself against your very similar hospital 20, 30 miles away or further, depending on where you are, you can do some benchmarking quite easily if you're using this sort of system. And it also allows you to monitor progress. You've got to monitor progress. If you don't monitor what's going on in your clinical areas, there's probably no point in actually doing it. So clinical decision support is something that I think is coming, and I think more people will be doing it out there. I know I'm getting quite a lot of questions at the moment about it, so I know it's coming. So we also business continuity planning was covered very smallly in the previous guideline, and we're very much a bit more savvy, let's say, around business continuity management now. It must obviously be in line with the ISO standard, which is 22301 for business continuity. Yes, I did have to look that up. The thing that worried me was, how do you test it to demonstrate effectiveness? And how do you identify any limitations? That's actually quite a complex question. We've tried to address it. I'm hoping that it's successful. And we've also recommended that you must include a recovery phase to make sure that your IT system is brought up to date as soon as you can. So yeah, I think there are things that we've been doing, but I think there are things that were not appropriately highlighted. So we have put in a section about red cell genotyping. Obviously in 2014, when we last rewrote the guidelines, red cell genotyping was happening, but very smallly, in a small way. Bob might tell me I'm wrong, that there wasn't much happening, but now it's very, very common to do a full, in inverted commas, red cell genotype for certain patient groups. I'm thinking of my patients with sickle cell disease. If I get a new patient with sickle cell disease, I immediately go into SPICE. Have they had a full red cell genotype? No, they haven't. Right, I need samples. I need to send them off. It's this sort of thing that's going to happen more and more with patients. I can see it happening with the MDS type patients, that we're going to want to match their red cell requirements better in the future. And to actually get those in there is important. We have recommended an electronic transfer of results from the reference service. We realise that at the moment that's not happening, but it's obviously, it's something that they're working on, and that obviously LIMS suppliers want to work on too, because you don't want to be manually transcribing those results. That's a high risk process in my eyes. If I can avoid manually transcribing anything, I will. And we've also recommended the use of algorithms when you're looking for red cell matches, and this is to actually what we want to say by then. So if you want a unit that's an R1, JK neg, WA neg, big S neg, etc., and use an algorithm in your system to search for that, so that you're not actually having to sit there going through all your units in your inventory. A lot of people now work in networks, so there'll be multi-sites. So it's really important that you can search across sites for these units. You might have them in stock, you might not. And if they don't have something in stock, you can build into an algorithm, N for Norman, as we heard from Rob, is not always clinically significant. So actually, if your patient's N negative, you might not want to match for that. If that's the only thing you can't match, you might say that's acceptable. But you want to be able to build that into algorithms, so you've not got a BMS in the middle of the night trying to work out which one he can drop or not. I think that's really important. It helps us, standardize processes. Data. Data is a bit of a passion of mine. I'm sure in another life I should have been a data analyst. So it's changed hugely in the last 5 years. I use data every day. Easy access to data is essential, and a lot of old LIMS systems were not great at allowing us to have data easily. I think this is actually improving, but we've recommended easy access to data as an essential. We obviously need to make sure that the data is used in compliance with GDPR guidance, because obviously that sort of sits among all our recommendations now. And we have put in a section around considering the provision to third-party organisations. By that, I'm talking about blood stocks management scheme. You know, can you get the data to initially populate blood stocks management scheme without having you type it in? That would be great. I'm sure that's something NHS BT would like. I know I've talked to them about it in the future. And things like we're all having to send more data off to NHS England, NHS EI, and things like that. So you just need to think about what is out there and what data provision you need. It's actually massive when you look at how much the managers spend providing data. So clinical audit, it's very much obviously related to data sets. We recommended the use of a standard data set as was done previously, and we're recommending coding for clinical information. So the coding was in suggestions for reasons and indication for transfusion, which was in the last guideline, has been updated a little bit. There is now one for COVID, obviously, and we're going on recommending that. And we're also recommending automatic links from other data laboratory systems, such as for hemoglobin, for a PT, is advantageous. We didn't think we could actually mandate that, but we thought it was important. I'll move on a little bit to the use of algorithms. So, you know, as I said earlier, we all use algorithms. So use algorithms to check that laboratory staff have selected the most useful, suitable unit of red cells, particularly for your patient. It was included in the current guideline. It's still obviously included in the new guideline. But what we have done, we've expanded that. We've said that you also need to consider it around the provision of FFP, which I'm sure people had, but we know that there's been quite a lot of shot incidents relating to FFP being inappropriately issued to patients for whom people have not been able to determine a blood group. Some people's systems allowed the issue of group O, which is obviously quite worrying in this situation. So we've expanded this to cover that sort of thing. And in the same vein, the other group of patients who we have problems making sure we issue the correct group of products to are the hematological transplant patients. And that's because when they're changing their group, it's quite complicated. So we're recommending built-in algorithms into LIMS systems to make sure that people are getting the right blood group of all the products, not just red cells. What have we added? I've been a lab manager myself. I wanted to add some templates to help us, help other people use this guideline appropriately. We've put in an operation requirement document, which is just a basic format of what you will use. And that's actually because you need to produce one of those before you can go out to tender. It's very similar to a user requirement document, but they're slightly different in certain ways. So operationally, you would talk about your domains, what specification of users you would like. In your user requirement, you want to say something like, I want an algorithm to block the issue of ABO incompatible red cells and things like that. They're quite obvious, but they're out there for people to use. And also the other thing I've done is I'm a big believer in gap analysis tools when it comes to guidelines. The first thing I do when I get a new guideline is write a gap analysis tool, which I sometimes share with my colleagues if anybody ever wants one. If a new guideline comes out, don't run an in, but you know, like ask if people want one. If I've got it, I'm very happy to share it. And what I think a gap analysis tool allows you to do, it allows you to assess your compliance with those guidelines. And it also allows you to think about what do you need to do to actually make yourself in line with those guidelines? What is the action plan? What's the time frame to do it in? Who's leading on it? Because, you know, like that, a new guideline comes out, the likelihood of you being 100% compliant with it on day one, yeah, it's possible, but quite low. So you need to, you will need an action plan to move forward. And I think it's things that having that evidence when it comes to UCAS inspections, MHRA inspections, they see that you're taking these guidelines seriously, and it just helps. So what's not changed? Yeah, we didn't change everything. Of course we didn't. So two key things that I would just like to highlight that we haven't changed is we haven't changed the recommendation that units from your blood service should be entered into the LIMS systems using the electronic dispatch note. This should be a standard. We felt quite strongly that saved a lot of errors and a lot of potential worry with people using electronic issues. So we've kept that standard in. And we've also kept in the recommendation that changes in patient demographics within the limbs, which is relating to blood transfusion, should be controlled by the transfusion laboratory. I know some people have struggled to get that in place because hospitals want people, ward clerks, etc., been able to change things on electronic patient records, which are then automatically updated limb systems, which is a bit worrying. So what we've actually done is we've strengthened the wording to try and encourage people to actually be a bit stronger about that. It's a really important issue, and it's so dangerous having people who don't understand the consequences changing patient demographics. I feel quite strongly about that. So that hasn't changed, but we have strengthened the wording somewhat. So I thought I would just mention recording of gender. It seems to come up on every webinar, meeting even, that I attend at the moment. So we didn't feel that we were able to address this because it is somewhat controversial. Of course it's controversial. The recording of a patient's sex and gender is problematic, but it's not just problematic to transfusion, it's actually problematic across healthcare as a whole. I spent weeks trying to find national recommendations for how we should handle patient sex and gender, and actually there isn't any. Currently there still isn't any. So we were like, okay, well that's good. So what we've actually done is we've indicated that you should ideally record both a gender and a sex, but the patient's sex at birth should be the one where algorithms run against. So things like patient with childbearing potential under the age of 50 should be run off the patient's sex, not off their current gender that they want to be known by. I will flag that this problem with gender is flagged every time we have a National Blood Transfusion Committee that I happen to attend, and we are trying to work in the background, or Shuba Alad particularly, is to try and get some proper information out there so that people can actually do it appropriately. So where are we? So I resubmitted the guidelines a week and a half ago for publication, having taken out bits and pieces. So fingers crossed it will be available soon. And that was it from me. Thank you very much.
To Rob, and is there any occasion you would do elution studies on a negative panel with a negative DAT and a negative auto, where you're querying something like AI HA?
Yeah.
Transfusion reaction.
Yeah, I mean, that's literally what I was just going to say. We would do it in the case of a suspected hemolytic transfusion reaction for definite. The panel's negative, the DAT's negative, but the patient's suffering from a query hemolytic transfusion reaction. We would still do an elution on that sample. The theory being that actually all the DAT positive cells have been destroyed. So therefore, there's no antibody bound to the red cells to cause a positive DAT, but there is an antibody lurking, or potentially an antibody lurking in that patient's plasma. So we would do an elution. We would do elution on that case.
Would that be presumably to remove whatever?
Yeah, it's well, obviously the DAT would have to be a certain strength for it to be visible, but so they could have a positive DAT, but we're not detecting it because there's very few cells. But the elution may concentrate the antibody. We may be able to detect it. We would do an enzyme IAT on the eluate as well as an IAT, just to see if there's something we can detect. We sometimes would do that in the case of passenger lymphocyte. If they're querying a passenger lymphocyte, so we'd look for anti-A and anti-B. So the antibody panels would be negative because they're all group O cells. But if we're looking for an anti-A or anti-B, if the hospital are querying a passenger lymphocyte post-BMT, we may do an eluate on those as well. So they're the only two situations I can think of currently. But generally, it's a sign of unannounced or surprising hemolysis, either following transfusion or not. Actually, we may do one if the hospitals request it. If they've got a worry that the patient suddenly started hemolyzing for no reason, we would still do an eluate, possibly if the DAT's neg.
Thanks for that. Julie, we've got somebody's asked in the questions, would you share your gap analysis tool? Now, am I right in thinking it's actually a tool that will go out with the guideline?
It is a tool that will go out with the guideline. If you want any, the last one I did was whatever the last guideline. Actually, if you look on the MBTC page on the emergency planning tool, There's actually a example of one of my gap analysis tools on there around when the emergency preparedness guidelines came out. So, you know, that's the sort of format I use. If anybody has got a burning desire to have one of the ones that's come out in the last 4 or 5 years, shout, you know, drop me an email. I'm sure my email's very easy to find, so I won't bother giving you it. You know, like I'll happily send you a blank copy. I'm not in the lab until Wednesday, so you wouldn't get it today, but you might get it later in the week.
Thanks, Julie, for that. I'm just going to ask Katie a quick question. In terms of the performance that you've seen in ERP, how many labs do you think are going to need performance letters or are going to achieve up in each exercise? And do you think that introducing the interpretation might reduce those numbers?
Yeah, based on the modelling we've done, it's approximately half a dozen people will probably get a letter, and some of those might be borderline, so 80 points not necessarily unsatisfactory performance. But I'm pretty sure that when we get to the interpretation where people can say, we've got a week, we've got a 1+, we've got a 2+, but we're not going to report that, I'm pretty sure we'll probably halve the number of letters.
So that's manageable, is it?
I think so.
There's another question from the Q&As for Rob here. In chronic anemias with frequent transfusions and autoantibodies, how often do you perform elutions?
How often do we perform elutions? It's sort of dependent on the patient's serology. I understand the question as in you've got a pan-reactive 4+ autoantibody, the patient's transfused 3 units every week. Do you do an LUA every time that sample comes in? The answer is generally no. We would probably do it if that was the case and there was no change in the strength of the reactivity, there was no change in the DAT specificity, we would probably do one once a month, once a fortnight. It very much depends on the number of units transfused. If the frequency is increased, if the DAT suddenly gone from IgG only to suddenly being IgG plus C3d, we would do an LUA then. If the reactivity of the autoantibody has gone from a pan-reactive 2+ suddenly to jump up to a 3, 4, 5+, we might want to do an LUA. The difficulty being that with the elution, it pulls off IgG. So if you've got a very strong IgG autoantibody, all you generally pull off is a pan-reactive autoantibody. So then we move on and we'll actually absorb the LUA. So we absorb the LUA that we pull off, we do an absorption on that to look at antibodies underneath. But yeah, I would say if the serology is stable, we generally do it once a month, depending on the transfusion frequency. But we certainly don't do one every time because, like you said, there's little. If the serology is not changed, there's little risk that there's a new antibody that's appeared if the DAT's as it was. Doesn't apply in every situation, but generally that's the rule of thumb.